Hi, everybody. Good evening, and welcome to another module on the sleep certification course. Today's module is module number 8, and we'll be speaking about RLS and PLMS from A to Z. At the onset, I'd like to thank the Indian Chess Society and especially Dr. Amita Nene, madam, for coming up with this beautiful sleep certification course, which is helping so many of us understand the nitty gritty of one of the most important things. We often spend about 30 to 35% of our life sleeping, yet give it so little importance. So, the purpose of this module and this education course is to help everyone understand the importance and inculcate in that in practice. So, Dr. Amita Nene, ma'am, thank you so much from the Indian Chess Society. J.K. Samaria, sir, Rajadhar, sir, special thanks to Sipla and Mr. Hitesh Pednekar for organizing this and helping us with all the logistic support. And the first 7 modules have been so fantastic. We've received such overwhelming response, and everybody has been participating wholeheartedly. Today's session is going to be no less than that, and we hope to even increase our number of participants because we've got a stellar session with fantastic speaker and panelists today. We are also going to be starting the sleep workshop once all our sleep modules are over. And that's going to be a hands on workshop, and which is going to help each and one of us in a better way to understand sleep medicine. So, without wasting further time, I'd like to introduce our eminent speaker for today, BP Singh, sir. BP Singh, sir, is an MD FCCP, is the founder MD, Midland Healthcare and Research Center in Lucknow, is the president of the Surya Foundation, which is an NGO. Sir is the head of the Department of Pulmonary Critical Care and Sleep Medicine at Midland Healthcare and Research Center, Lucknow, a member of the ATS, ERS, AASM, a life member of the ICS, ISCCM, NCCP, IMA, the founder member of the board of Southeast Asian Academy of Sleep Medicine, and the ex-president of the SEAASM. Sir has received numerous awards, the Health Icon Award from the Times of India, the Shriji Foundation Award in 2016 and 17, Trivedi Foundation honors as an exemplary and selfless contributor towards the society, the Ajara Earth Community Humanitarian Award for honorable service to the society, Inspiring Pulmonologist in 2019 by the Economic Times in Delhi, Legend of Economic Times Award in 2023 at the Times Networking Award of 2024. Sir has a special interest in airway diseases, interstitial lung disease, critical care, sleep medicine, and research, and has conducted more than 20 national and international trials with numerous publications in various articles in reputed journals such as the ERS, Journal of COPD, Respiratory Medicine, IGRI, etc. And we have no one better than BP Singh, sir, to talk on restless leg syndrome and PLMS, a complete overview. I warmly welcome you, sir, and hand over the session to you.
Good evening to all of you, and especially my thanks to Dr. Avya for giving such a kind introduction. So I will start my presentation. It is a very important topic, as he has already mentioned, that basically, just a moment. Can you see my screen? All of you can see my screen?
Yes, yes.
Is it visible? Okay.
Yes, sir.
Okay.
Yes, sir.
So this is the topic actually what we are going to discuss it today. If you look at this format, the International Classification of the Sleep Diseases, they have described sleep disorders in various headings. In the sleep-related movement disorders, International Classification of Sleep Disorder 3, they have described restless leg syndrome and periodic lung movement disorder, and another group, the other sleep-related movement disorders. Today we'll be discussing about the RLS and PLMD. Apart from this, just to name the other sleep-related movement disorder, the propiospinal myoclonus at sleep onset, that is the hypnic jerks, the sleep-related bruxism, sleep-related leg cramps, sleep-related rhythmic movement disorder, benign sleep myoclonus of infancy, sleep-related movement disorder due to medical disorder or because of the medication or the substance, and the sleep-related movement disorder which are unspecified. So these are the sleep disorders, especially the movement disorders, what we are actually discussing in the sleep-related movement disorder. Today, we will be focusing on just the RLS and the PLMD. So just moving to the, just a moment, probably. Okay, this, if we, just to introduce the clinically significant RLS, defined as occurring at least twice a week and associated with at least moderate distress, is present in around 2 to 3% of the adults and 0.5 to 1% of children. This is given by the American Academy of Sleep Medicine in this year, January, actually. This data have been published. In adults, the RLS, the restless leg syndrome, is roughly 50% more prevalent in females, and some of which is related to pregnancy and also more common in those of the Northern European heritage. Although it is also common in our population in India also. So, once asleep, people with RLS often exhibit periodic leg movements during sleep, PLMS also, which are detected on polysomnography as brief 0.5 to 1 seconds, recurrent flexion movements of the lower extremities that occur roughly every 15 to 30 seconds. One thing which is important, you should note at this point, that RLS patient, they also have the PLMS, and almost 80 to 85% time, the RLS patient will have this component also. PLMS in people, periodic leg movement in people with RLS, occur particularly during the first 4 hours of sleep, and have high night to night variability in both adults and children. So, just if you talk about this disease, this is also known as Willis-Ekbom disease. It exhibits a higher prevalence in women, as already mentioned, and it has a significant familial association also, characterized by irresistible urge to move the lower extremities, frequently accompanied by dysesthesias, means the painful movement. Dysesthesias are the painful movement. May present as neuropathy, akathisia, spasticity, positional discomfort, joint discomfort, and nocturnal leg cramps are among the conditions that can present with symptoms resembling restless leg syndrome in adults, and growing pains, leg cramps, and behavioral issues are the mimics in children. So it can have a varied presentation. In adults, in a very clear cut, while in children, it may also present as a behavioral issue. A critical and well documented overlap exists with sleep disorder breathing, that is most notably with the obstructive sleep apnea, we all know. And it can complicate the presentation of the obstructive sleep apnea and have a different ramification. It is understood that intermittent hypoxia and sleep fragmentation secondary to untreated OSA may directly exacerbate or mimic the clinical presentation of RLS, plausibly through the disruption of the central dopaminergic pathway. And that is very important, and we will discuss it in a bit detail in the next coming slides. What is the definition of this restless leg syndrome? Actually, the International Restless Leg Syndrome Study Group has defined this criteria in year 2014, and they have given these 5 essential diagnostic criteria. Number 1 is the irresistible urge to move the legs, usually but not always accompanied by uncomfortable and unpleasant sensation in the in the legs. So it is the irresistible urge to move the legs while patient is sitting idly, and at that time patient starts feeling that they should move the leg. Symptoms that begin or worsen during the periods of rest or inactivity, such as lying down or sitting. Symptoms are partially or totally relieved by movements such as walking or stretching, at least as long as the activity continues. So patient starts feeling comfortable while the patient starts moving from the lying down or sitting posture. Symptoms only occur or worse in the evening or night than during the day. And the fifth is the occurrence of the above feature is not solely accounted for as symptoms primarily to another medical or behavioral condition like myalgia, venous stasis, edema, arthritis, leg cramps, positional discomfort, and habitual foot tapping. So, duration, if you look at the duration and nights per week, it is episodic or progressive. Family history, maybe there are, you can ask the question actually in the clinic to the patient that are you restless in the mind or in the body, to differentiate insomnia versus the restless leg syndrome. So this is how you start, that how many times you have this symptom in the week or in the night, and how the behavior is. And you can ask the patient that about the snoring or the apnea, because it is many times it is accompanied by the sleep apnea also. Look at the respiratory event related arousals, ask for the daytime sleepiness, and you can do the scoring. Then upper sleepiness scale, just look at the sleepiness in the patient, periodic lung movements in the, and also about the timing of it, that whether in the first half or the second half of the night. And witness history and smartphone, it means that somebody has recorded in their phone that their movement, the how it looks like and how the movement is going on at to what time it is continuing. Drugs and their timing include nicotine, especially the studies have shown that very clearly that 12% of the smokers have RLS. So while you are taking the nicotine or caffeine or the alcohol, and their correlation with the restless leg syndrome. One very important question, which has very high sensitivity of 100% and 96.8% specificity for the diagnosis, is that when you ask that when you try to relax in the evening or sleep at night, do you ever have unpleasant, restless feelings in your legs that can be relieved by walking or movement? This question has very high sensitivity and specificity for the diagnosis of restless leg syndrome. So this thing you can ask to your patient, and you can be sure that whether your patient is dealing with RLS or not. It, it is a disease which has got various association with other problems. It increases with age, obesity, physical inactivity, as already mentioned, it is more common in females than males. There is a family history of 40 to 50% of the patient, often with younger age of onset of the disease. It is very closely related with the iron deficiency. It is also associated with diabetes and dialysis patient of chronic kidney disease, patient with spinal disease, peripheral neuropathy, and possibly any long-term condition that immobilizes these patients. They can also be associated with RLS. Pregnancy, thought to relate to the physiological iron deficiency. Gastric binding or surgery can also be associated with RLS. And that drugs, there are many drugs which can aggravate or worsen this RLS or the PLMS, especially the dopamine depleting medications like metoclopramide or antipsychotics, antidepressant like mirtazapine or venlafaxine. They increase 3-time RLS and 5-time increase in PLMS. Drugs like melatonin, antihistamine, and as already mentioned, that nicotine, caffeine, and alcohol are closely associated with the incidence of the restless leg syndrome. Now coming to the pathophysiology. Here we'll have some time to understand exactly how it evolves. If you look at the component of the RLS syndrome, in the pathophysiology there are the four main components actually. This is the A11 nucleus. If you look at here, it is a group of dopamine producing neurons in the brain. In this model, the A111 nucleus is the central player. This you all must understand. Its job is to send dopamine signal down to the spinal cord to regulate sensory and motor signals here and here. And it has got an inhibitory effect. In the spinal cord, in the dorsal horn, this is the receiving area in the spinal cord for sensory information coming from the body, like touch, pain, and pressure from the legs. So from here, the afferent sensations are going to the dorsal horn of the spinal cord. And from there, it can have the perception of the sensation of these like touch, pain, and pressure from the afferent organ. Here it is the legs. And there is a somatic circuit. These are the nerves that control voluntary muscle movement and process sensory feedback from these muscles. So it is a somatic circuit, and from these muscles, these are basically the nerves which are going to the dorsal horn. There you can have the sensation. And there is an autonomic circuit. These nerves control involuntary functions like blood pressure and adrenaline release from the kidneys. And how the circuit is supposed to work? There is a descending control from the brain. The A1 nucleus sends inhibitory signals shown in red with a negative sign down to the dorsal horn of the spinal cord. Essentially, it tells the spinal cord to calm down and not overreact to normal sensory input from the legs. This is a crucial braking system. This is the very important point actually you must understand here. It is the A11, which is the group of dopamine producing neurons in the brain, which is important for having a braking system on the spinal cord. Sensory input from the legs in the section 3 here. Your lung muscles are constantly sending signals up to the spinal cord through muscle afferent nerves, and some are low threshold, means the normal sensation. Some are the high threshold, where like the pain-like sensation. The A11 braking system helps to filter these signals so you do not feel every little thing. So you will not have exaggerated response to the signals which are normal to the body. What goes wrong in the restless leg syndrome? There is a loss of inhibition of the A1 neuron, which becomes dysfunctional or die off. As a result, they stop sending these inhibited dopamine signals to the spinal cord, and the brakes are now off. And the spinal cord hyperexcitability is there. Without A11's calming influence, the neurons in the dorsal horn become hyperexcitable. Now, normal or low threshold signals coming from the legs are misinterpreted by the spinal cord as something more urgent or unpleasant. So there is a hyperexcitability in the spinal cord, and there is a urge to move. This flood of unfiltered sensory information going up to the brain from the hyperexcitable spinal cord is what creates the uncomfortable sensation and the overwhelming urge to move that characterize the restless leg syndrome. Moving the legs generate new sensory signals that can temporarily distract or override the abnormal ones, providing the relief. This is what the whole mechanism is there. And the most important thing is that here the A1, A11 neurons, which becomes dysfunctional, and they are the important cause of this RLS. So this thing you must be knowing, and that is the reason we are having the drugs which are affecting these neurons, this pathway, and producing the result in these subgroup of patients. So how to diagnose restless leg syndrome? It is the self-test. You can ask your patient, do you have difficulty falling asleep because of an urge to move your legs? Do you feel an itching, a crawly sensation on your legs when you lie down or go to sleep? Do your legs seem to feel better when you walk, stretch, or make other movements in the evening or at night? If you answered yes to any of these questions, you may have restless leg syndrome. That is how you make the diagnosis of your patient. And what is the role of PSG in this subgroup of patient? If patient has restless leg syndrome, the doctor should ask for the medical history and the medication. Patient should be advised to keep a sleep diary for 2 weeks to document when they sleep and for how long, so that you can identify what are the disturbance patient is reporting. And blood tests should also be done to include that should include the measurement of the ferritin and an iron panel. And one thing important, a sleep study is not required to make the diagnosis of restless leg syndrome, but it may be used to diagnose underlying sleep disorder that may be causing sleep disruption. So you can do the sleep study, but essentially not for the diagnosis of RLS. You can take the test for those patients who have associated other sleep disorder problem. And there is a sample of the RLS symptom diary, and you can maintain. You can ask the patient to maintain it, and by this you can judge whether this patient is having, how much of the symptoms are there and how the patient is presenting. Then coming to the ASM guideline in 2024, which fundamentally altered the diagnostic approach by positioning iron deficiency as centrality to the pathophysiology of the RLS. The American Academy of Sleep Medicine has given this statement. There is a role of cerebral iron deficiency in causing the RLS, and it is caused by the low iron in the brain, which is needed to make dopamine. And the recommended lab test, as already mentioned, the serum ferritin level, the transferrin saturation, two important one. And the new actionable threshold for this is the treatment is recommended if serum ferritin is less than 100 nanogram per ml or transferrin saturation less than 20%. These are the two basically threshold which has been defined by the ASM for the treatment. Therapy, how it evolved over the period of time by the Willis in 1685, 85, giving the uh, hint that opium and cocaine may be effective in treating. The Egbaum in 1944 first time noted the iron therapy was of the benefit in this subgroup of patients. In the 1962 by Lugarasi, they identified the periodic loop movements in sleep patients, and the first trial of levodopa was done in 1987 by the Equinar, which was published in the BMJ. In 2004 to 2008, the dramatic effect of the dopamine agonists were identified and shown with the striking reduction of symptoms and periodic leg movement in this subgroup of patients. And PLM also, which was already I have mentioned, that it is very common in the patient of the RLS. Around 80 to 90% of the patients with restless leg syndrome will also have the periodic leg movement. And you can see here how it is seen on the polysomnography. Here the muscle activity you can identify here, the left anterior tibialis and the right anterior tibialis. These are basically the curves showing the activation of the muscle, and the periodic limb movement is shown in this hypnogram. What is the therapy which is recommended for the restless leg syndrome? The first line therapy given by the American Academy of Sleep Medicine, published this year only. The current consensus treatment guidelines recommend the first line therapy is the iron, oral and IV iron treatment. Second is the alpha 2 delta ligands like gabapentin, inacarbil, which is a prodrug, or pregabalin. The second line therapies are, although they were initially considered to be the first line, but now the ASM recommendation is saying that it is a second line therapy because of the effect of the augmentation of these drugs. Augmentation effect. What is the augmentation? Augmentation is the worsening of the RLS symptoms over time from the drugs that act on the dopaminergic system. And there is an increase in the symptoms as the symptoms start proceeding in the daytime, and not only in the evening or the night time, but it can start happening in the daytime also, and the severity also increases. This is how the augmentation has been defined. An estimated 5 to 10% of individuals taking dopaminergic medication experience new onset augmentation each year. Medication in this drug class include ropinirole, pramipexole, and the rotigotine patch. So these are the drugs which were initially used as a first line, but now they have been, because of the augmentation effect, they are used as a second line therapy when the first line therapies are not effective in the refractory group of the patient. This is basically the American Academy of Sleep Medicine, which was this data was published this year in January 2025, and they have very clear cut recommendation, and you can everybody can take the snapshot of this chart and recommendation. Here, what they recommend: the treatment of the restless leg syndrome and the periodic limb movement disorder. The ASM clinical practice guidelines says that serum iron studies replace with oral or IV serum ferritin if less than 75 nanogram per ml. Means if there is less than 75, you have to replace with the oral or IV, and only IV ferritin between 75 and 100. For children, replacement if ferritin is below 50 nanogram per ml. This is what the replacement therapy is recommended for the iron deficiency. Address lifestyle factors, first including alcohol, caffeine, antihistaminic, serotonergic drugs, antidopaminergic, and untreated obstructive sleep apnea. They all need to be looked at after identification of the RLS for the treatment. Gabapentin has a strong recommendation for the treatment. Pregabalin has a strong recommendation for the treatment. It advises against the use of pramipexole, rotigotine, ropinirole, and it may be used to treat RLS in patients who place a higher value on reduction of restless leg symptoms with short-term use, and a lower value on adverse effect with the long-term use, particularly the augmentation. So it can be used in a subgroup of patients where the symptoms are much more persistent. Then you might use it for the short term. However, those patients who are able to tolerate the symptom, then they can use it for the long term also. This is a chart published in that particular statement. I will not go into the detail, only what they have said that initially the gabapentin, enacarbil, and pregabalin is strong, and IV ferric maltose, a strong for recommendation is there. And for others, there is a conditional recommendation, and for most of them, there has been conditional against. So I will not go into the detail. Now coming to the what is the dosing? The gabapentin is having a 5 to 7 hour half life, and it should be taken 1 hour before bedtime. And dose is 100 to 600 milligram. Pregabalin has got a 6 to 10 hour half life and 1 hour before bedtime. It is good for anxiety, and dose ranges from 150 to 450 milligram. The side effects are the dizziness, sedation, weight gain. 14% increase in BMI by the 600 milligram a day of pregabalin has been recorded. So significant, this side effect that weight gain is important for many of the patients. And opiates and clonazepam helpful for some, potential for dependency and worsening of snoring and the sleep apnea has also been one of the recommended drugs for a select group of patients. And iron is very important. Iron, if low, oral, if it is low, you can start with the oral or the IV therapy. There is a class 1 evidence for short-term benefit for the dopaminergic drugs also. However, as already mentioned, it should be not used as a first line treatment. However, they can be used in the select group of patients. For the dose for this is the ropenolol is 0.5 milligram to 4 milligram in 2 divided doses. It has got the shorter half-life of 3 to 6 hours and side effects of nausea for about 10% of the patient. Pramipixole has a longer half-life but more side effects including peripheral edema and postural hypotension. Roticotin patch 1 to 3 milligram, and it has got a drug related actually contact dermatitis. 4% patient have rash under patch, and but only there is a slow release reduces nausea and possibly augmentation, and the dosing is once daily. So in that way, it is used in select subgroup of patient, and this therapy has been utilized. It is less sedative, good for mood, but it has got augmentation effect. That is the reason it is not used as a first choice. Now coming to the emerging and the future developments. There are bilateral high frequency peroneal nerve stimulation. Example is the Noctrix Health NT into 100 tonic motor activation system, the TOMAC system, which received FDA de novo approval in April 2023. It is a non-pharmacological wearable device that delivers electrical stimulation to suppress RLS symptoms. This is the device which are being developed and approved by the US FDA. Although ASM provides a conditional recommendation for its use in patients with moderate to severe, those patients who are drug refractory are having drug refractory RLS. In the genetic also, an active investigation at institutions such as Johns Hopkins is focused on elucidating epigenetic factors and the functional roles of the identified risk genes like MEIS1, BTBD9, and PTPRD with the goal of developing personalized medicine. And another modality, the non-pharmacological, there has been a 2025 pilot investigation of cell-administered hydrotherapy and acupressure demonstrated feasibility and suggested potential benefit, thereby warranting a larger, well-designed confirmatory study for this subgroup of modality actually for the treatment of the patient, the RLS. So this is how the evolution is occurring in the treatment of the RLS. This is the recommendation given by the Mayo Clinic proceeding, which was published in 2021 for the intermittent RLS. You can start with the non-pharmacological therapy, and on demand, you can use the medication of the levodopa, the benzodiazepine, or low potency of the opioids for the intermittent RLS. For the chronic and persistent RLS, again, the non-pharmacological therapy has to be there, and you can start with, as a first one, the alpha to delta calcium channel ligands. Examples are the gabapentin, the pregabalin, or the gabapentin in carbon. If contraindication to these ligands are there, then you can use the drugs like pramipixole, ropenolol, or the roticotin patch. Those patients who are having the refractory RLS, check the iron stores, replenish iron if needed, consider and correct other possible exacerbating factors, Consider the combination therapy. Here they have recommended if the patient is not responding on a class of drug, you have to combine therapy as we are doing in many forms of the therapy, especially in asthma, COPD, even in tuberculosis and so on. So you can combine the treatment for the having much better efficacy. And you can consider the opioid monotherapy also, what the recommendation is saying. In the management of uh, this RLS in a group of patients where the iron deficiency is there, and most important thing is that iron stores should be checked. If the serum ferritin is less than 100, symptoms are severe, IV iron therapy should be considered in these subgroup of patients. You have to identify whether your patient is having iron deficiency or not. If it is there, then you have to correct it. Other exacerbating factors should be sought if include the use of medication that can worsen restless leg, change in lifestyle such as more sedentary behavior or shift work. So, or other causes of sleep disturbance such as sleep apnea or the chronic insufficient sleep. You have to look for all these factors and eliminate it and improve it. Consider combination therapy as already mentioned, and just continue with the therapy and just see if the patient is responding to this treatment or not. Consider substituting an opioid such as oxycodone, hydrocodone, or morphine or methadone. In particular, consider the low dose methadone therapy for the severe refractory RLS resistant to other treatment. So, in that way, you can treat your patient of RLS. The doses for the opiates in the RLS, this is all, although it is known to all of you, the tramadol, the standard starting dose is 50 mg or 100 mg ER to the 100 to 200 total daily dose. Codeine from 30 milligram to 60 to 180 milligram. Control release morphine from 10 to 15 to 15 to 45. Oxycodone 5 to 10. Hydrocodone 10 to 15. And methadone from 2.5, it can be started. And buprenorphine 0.5 to 1 milligram is sufficient sublingual tablet to control the symptom to start the therapy. Management of RLS during pregnancy is very important. Non-pharmacological therapies are strongly preferred with special attention to moderate exercise and correction of iron stores by oral or, if necessary, IV administration of iron during the second or third trimester. This is important, especially in the pregnancy. You can have RLS much more common than the non-pregnant females. Medication at the lowest effective doses should be used if required. It should be reserved for severe RLS, preferably only in the second or third trimester, to reduce any risk of inducing congenital anomalies, and physicians should work closely with the patient's obstetric provider. The risk-benefit ratio of drugs in the pregnancy should be carefully considered and discussed with each patient. And these recommendations are based on the two consensus publications actually. About the management of the RLS in childhood, although most of us are the adult physicians, but the non-pharmacological therapies, including consistent bedtime routine, avoidance of sleep deprivation, and elimination of caffeine should be tried in this subgroup of patients. If possible, selective serotonin reuptake inhibitors should be avoided. The mainstay of RLS treatment in children is again iron replacement. Serum ferritin concentration should be measured, and iron supplementation should be prescribed if the levels are less than 50 microgram per liter. As in adults, the first line therapy in children should be the alpha 2 delta ligand. It may be the gabapentin, it may be the pregabalin. The other drugs that can be considered include clonazepam, dopaminergic agents, and clonidine, but potential side effects should be carefully considered. What are the periodic limb movement? The PLMD is primarily caused by dysfunction in the central nervous system dopaminergic pathways. It is the similar pathway which we are talking the RLS, and its etiology is multifactorial, involving medical conditions, medications, and lifestyle factors. The primary mechanism involves the dysfunction in the central nervous system dopaminergic pathway, particularly in the basal ganglia and spinal cord, resulting in the episodes of simple repetitive muscle movement. That is what the PLMD is. There are several medical conditions which are associated with this disorder, including the iron deficiency, especially low ferritin level below 50 nanogram per ml, the renal failure, the diabetes, the peripheral neuropathy, spinal cord injuries, and the neurodegenerative disorders like the Parkinson's disease. So all these can cause the periodic leg movement disorder. Certain medications can trigger or worsen PLMD, including antidepressant, particularly the SSRI and SNRI, antipsychotics, lithium, and some antihistamines. So what are the key factors? Again, the key factors is the same which already I have discussed. The iron deficiency, particularly the low ferritin, is a significant contributor to the PLMD, as evidenced by the American Academy of Sleep Medicine suggestion to use ferrous sulfate in patients with appropriate iron status. Renal patients with renal failure, diabetes, peripheral neuropathy, spinal cord injuries, and neurodegenerative disorders like Parkinson's disease are also associated with PLMD. Medication is already mentioned. Genetic factors likely play a role as PLMD sometimes run in families. Age is another factor, with the prevalence increasing significantly in the older adults. As the age advances, the incidence of the disease also advances. If you look at the etiology, it is a complex mechanism, and multifactorial factors are there. And several studies have investigated the underlying mechanism and potential causes of PLMD, especially the dopaminergic dysfunction is the key factor in the development of this disease. Iron deficiency has also been proposed as a potential contributor. Other potential underlying mechanisms include the thalamic glutamatergic hyperactivity, cortical subcortical interplay, and a pure motor mechanism originating in the spinal cord. It has also been associated with various medical and neurological disorders, as already I have mentioned, including sleep apnea syndrome, narcolepsy, and REM sleep behavior disorder. What are the symptoms of the periodic limb movements? Normally, you are unaware of the movements. This can make it very hard for you to know if you have periodic limb movements. Sometimes, someone who sleeps in the same bed with you would be more likely to notice the movements. You might have periodic limb movement disorder if someone else told you that your body makes unusual repetitive movements while you sleep. These movements tend to occur in your lower legs. You feel, although it can happen in the upper limb also, but usually it in the lower legs. You feel like you are never well rested even after a full night of sleep. You are often very tired during the day. It is important to know if there is something else that is causing your sleep problem that may be a result of one of the following: another sleep disorder, for example, the RLS or the sleep apnea, any medical condition which I already enumerated, medication, and a mental health disorder or substance abuse. Abuse may be there to causing the additional problem to your patient. For the diagnosis of the periodic leg movement disorder, important thing is that you have to use polysomnography, a history of associated sleep disturbance, whereas the RLS diagnosis does not require PSC. That thing, this thing should be noted very carefully, that for the disease diagnosis of the PLMD, you require a PSC. Officially, there are four criteria that guide the diagnosis of PLM. They are PSD demonstrating highly stereotyped repetitive limb movements.
Sir, can we
The
end in
PML,
5 minutes? Sorry, sir. Can we end in 5 minutes, sir?
Yes, I'm just approaching that.
Yes, sir.
Index, PLMS index, more than 5 per hour for children, more than 15 per hour for adults. And PLMS causes clinical sleep disturbance of any type and impaired daytime functioning. And it is not better explained by other disorder. And this is how it looks like on the polysomnogram with the basically the movement of the limb. You can see there is a arousal. Clinical significance and treatment. Treatment is almost similar, actually. As I mentioned with the RLS, it is a similar treatment which you follow in the PLMS also. And in the American Academy of Sleep Medicine has given this recommendation. You can use the same drugs like the alpha 2 beta delta ligands like gabapentin, pregabalin, gabapentin, enacarbil, and dopaminergic agents like romiprol, pramipexole, and rotigotone. And you can use other things like sleep hygiene, exercise, and lifestyle modification. And most important thing, you all must remember, that is the iron supplementation when the iron is deficient. These drugs are contraindicated. So key takeaways are for this talk for the RLS and periodic limb movement disorder. There is centrality of iron assessment. RLS and periodic leg movement disorder should be conceptualized as a state of functional brain iron deficiency. It is imperative to assess and aggressively treat iron insufficiency. Prioritization of alpha 2 delta ligands. These agents are the established first line pharmacotherapy, thereby avoiding the significant risk of augmentation associated with the dopamine agonist in the RLS and also in the PLMD. Their necessity of the airway management is important. The association between the RLS and OSA is robust. Effective CPAP therapy constitutes a potent treatment for the RLS symptoms in this subgroup of patients where it is having basically since RLS and OSA both together. There is integration of novel technology, that is nerve stimulation devices offer a safe and effective non-pharmacological alternative for refractive cases of RLS. And many people with RLS have PLM, around 85%, but most people with PLM will not have RLS, only 20 to 30%. So with these words, I like to thank all of you for the patient hearing. Thank you.
Thank you, Singh sir. I think that was a fantastic talk. You've covered each and every aspect of RLS and PMLS in such great depth. You started by simplifying with the definitions, the etiology, the pathophysiology to the diagnosis and treatment of RLS, and you've done the same with PLMS. And you've taken the important 2025 guidelines and educated us all and told us the importance on how to find these guidelines and enact on it. I think it was an excellent session, and our audience has been fantastic. We've got almost 2,600 logins who have been patiently listening to your talk, and we've got a plethora of questions, and everyone has been overwhelmed with your wonderful talk. So thank you, sir. I now invite my esteemed panelists, and I'm really excited about this. I want to first invite K. Satish, sir, whom I know for the last 15 years. It's been sort of a privilege. When I was studying and doing my undergrad and postgrad in Karnataka, he was a legend and still is a legend in the field of respiratory medicine. So, sir is an MD, DNB, FRCP, a fellow of the British Thoracic Society. He's the chief pulmonologist at Manipal Hospital, Millers Road, and Chest and Maternity Center in Bangalore. And presently, sir is the president of the Karnataka Pulmonology Association, which in fact he helped start about 8 to 9 years back and has been instrumental in the functioning of the KPA and the Pulmocon. So, warm welcome to you, sir.
Thank you.
Next, I have Dr. Sajitha M. Madam is from Kottayam. Madam is an MD, Pulmonary Medicine at the Kottayam Government Medical College, Kerala, and an associate professor at the same institute. She has a special area of interest in interstitial lung diseases, obstructive airway diseases, and interventional pulmonology. Is a life member of the ICS, IAB, and the IMA, and has 20 plus published papers on interstitial lung disease, COVID immunology, diagnosis of lung cancer, drug-induced diseases in various index journals. Looking forward to hearing from you and learning from you, madam. A warm welcome to you.
Hello, everyone. Thank you for the time.
I have next with me Dr. Ankita Gupta. So, madam is from Delhi. She's an MBBS DNB respiratory medicine and a member of the National Academy of Medical Sciences. Currently is an associate professor in the Department of Respiratory Medicine at UCMC Delhi. Is an executive member of the UCMS Journal of Medical Sciences and a life member of the ICS, ERS, and IAB. She has the Magnanimous Award of Excellence in Healthcare by the Honorable Chief Minister of Delhi, Ms. Rekha Gupta ji, a jewel of IMA, the Chikat Sevak Seva Samman by the IMA East Delhi branch, among many others. She has got the Certificate of Appreciation by National Medicos Organization for conducting numerous medical camps. Her area of interests are management of obstructive airway diseases, allergies, sleep disorders, tuberculosis, interventional pulmonology, and has conducted and organized various awareness programs for the same, and has numerous national and international original articles, including book chapters. So, warm welcome to Dr. Ankita Gupta.
Thank you so much for the warm welcome. Thank you.
And last, but not the least, my dear friend and colleague from Bombay, I have Dr. Saurabh Mandilwar. He's a consultant pulmonologist at the R.N. Cooper Hospital and Nanavati Max Hospital at Juhu, Mumbai. He has done his DNB from the prestigious Leelavati Hospital and Medical Research Center. Is a consultant pulmonologist at various hospitals in Bandra Khar, Santa Cruz, has more than 10 years of experience and has been a frontline COVID warrior for the last 2 years at HBT Trauma from 2020 to 2022 and has worked there as an intensivist. He's a member of the ICS, CCI, ERS, and ACP, and a wonderful human being and a colleague I reach out to very often. So, warm welcome to you, Saurabh. Yes. Saurabh, you have to unmute yourself.
Yes, thank you, Avya. And let me introduce our moderator today, Dr. Avya Bansal. He is a dear friend. He is a colleague in Mumbai, MD, DNB, and consultant pulmonologist in Bombay Hospital and Medical Research Center. He is honorary pulmonologist in Mumbai Police Hospital. He has lung care clinic in Bandra. He has got Sir Ratan Tata scholarship during MBBS. He has been university topper, gold medalist since beginning MD, during MD. And he has got ERS travel grant for best paper in Madrid 2019, ERS training in ILD, Germany, and pediatric asthma in Austria. So he has special interest in obstructive airway diseases, OSA, and ILD. And he has set up adult vaccination OPD in Bombay Hospital, sleep clinic at Bombay Hospital. And he is one of the leading practitioners now, emerging as a leading practitioner in Mumbai.
Thank you, Saurabh. I think that was an overwhelming welcome. And now we've got a full-on session with our top 4 panelists and wonderful speaker, B P Singh, sir. So, now before we go on to the audience questions, I want to pick each and every one of yours brain, and I'm going to start with our senior most legend, Satish, sir. Satish, sir, although a lot of things have been covered by Singh, sir, but I still want to know what is RLS and what is the incidence of RLS in the Western data and in your practice, sir?
Okay. So thank you. Good evening, everyone. Thank you, Al, and my fellow panelists. And thanks for inviting me, ICS, today for the webinar. It was an excellent talk by Dr. Singh, covering almost every aspect of RLS and PMLS and going deep into the pathophysiology, the treatment aspect, the NO guideline. Thank you, Dr. Singh. And coming back to my question on restless leg syndrome, it's a neurological disorder. He defined it beautifully, that causes a very compelling and overwhelming urge to move the lower limb, especially the distal part like a toe and ankle, usually in response to a sensation, an uncomfortable sensation like tingling, or maybe crawling, or maybe like aching. And these symptoms generally worsen when there is inactivity, when there is rest, and which means like in the evening hours or when at night. And these are temporarily relieved by movement. So it's a strong urge to move the lower limb, move the legs. And that is the definition of RLS. Coming back to the incidence of RLS, and Dr. Singh also mentioned about it, it's not very uncommon. All of us in our practice have seen RLS, and especially with the sleep studies that comes up. And we see, there is a leg movement, periodic leg movement, restless leg, and so on. So as Dr. Singh mentioned, that the incidence in prospective studies is something like 1.2, 1.7 per year, which means that if you see patients each year, a new patients, so there will be about 1.7% of previously unaffected individuals who develop RLS. The cumulative overall incidence reported over a period of 5 years in the literature is about 7 to 9%. So it's not very uncommon to see this kind of a incident. And as we move on with the incidence, it increases with age, particularly if it is more than 70 years, you tend to see more and more patients reporting RLS. Adolescents maybe less, maybe about 2% to 3%. Adults, slightly lower, and middle-aged and elderly tends to go up, almost, as I said, 8 to 11%. So in my practice, if you ask me, I haven't really done any studies or anything, but it's uncommon at all. I do see patients complaining about it many a time. As Dr. Singh said, it's mostly symptomatic. You don't require a sleep study. And if you probably pay attention to the patient who complains about, on a busy outpatient, sometimes it's very difficult. Okay, he's saying, my legs are aching, pulling, and I have to keep moving. We think it is cramps, it is due to weather, and so on. If you really carefully study the incident, that's why the incidence also is not very clear. It can be, different, because there are not very specific symptoms of RLS. Thank you.
So very well said, sir. In fact, we've got a couple of data and studies from India. So Uttarakhand tells us that it's as high as about 12%.
Correct.
High altitude, it increases the risk of RLS. That's what they've found. And two papers from, in fact, Bangalore itself, one sort of underreported it at about 2%, and the other one was at 7%. But like sir said, it's an important system, and the diagnosis is often missed, and somehow we tend to overlook it and attribute it to anxiety, and often rub it under the shoulder. So which is why I think we need to take it more seriously and give it more thought. And probably if we do that, we'll have the incidence as high as the Western world, which documents to about 20 to 30% of all men and women above the age of 45 suffer from RLS. So thank you, sir. Now, my next question is to Sajitha, madam. Madam, what is the diagnostic criteria for RLS? When would you label a patient to have RLS in your practice?
Avya, and it was a wonderful presentation by Dr. B P Singh. Actually, though it has been covered, I'll just go into the diagnostic criteria. Both the International Sleep Disorder has mentioned the diagnostic criteria along with the ASM, and the main questions that has to be answered. It's mainly a clinical diagnosis, the restless leg syndrome. So the main questions we can ask, and all of the clinical criteria has to be there, whether the patient has an uncontrollable urge for this physical activity in his legs, and which is worsened during inactivity, periods of inactivity, and it gets better as the patient is becoming active, or when he's walking or something, and it progressively worsens during the night time. And it is not associated with any of the other medical disorders like leg edema, paresthesias, arthritis, discomforts, etc. So all these 5 criteria has to be met for this restless leg syndrome. And there are 2 clinical specifiers for determining the chronicity of the restless leg syndrome. That is, if the patient has felt this uncontrollable urge any time during his lifetime, that can be a intermittent restless leg syndrome. But if he has felt it during twice weekly in the past 1 year, then he's a chronic syndrome. Actually, it is a chronic RLS syndrome, and it has to be dealt with seriously. And some points which actually some points which actually tells us whether it affects his daily inactivity, then also the patient has to be dealt seriously. That is also very important. That question also has to be addressed. So these are the diagnostic criteria. All the 5 questions have to be answered, and you have to see whether it is a chronic restless syndrome or intermittent one, and whether it affects his daily activity, so that the treatment can be tailored accordingly.
Often the patients tell us that it's like a yawn. It's an urge which can't be controlled. It's not in our hand. It's not something we're doing intentionally. And what also helps us to understand is that the symptoms worsen by relaxation. So when the patients are often distracted, the symptoms of RLS and the severity is often under check. So a couple of more things which help us, not a part of the criteria, but to help understand that this is where we need to look at. This is probably a case of RLS. Thank you, madam. Dr. Gupta, I'd like to ask you, what are the types of RLS? Do we have a primary, secondary RLS, and what does it mean by that?
Thank you so much for the question, and I really appreciate the wonderful webinar by Dr. B P Singh sir, and thank you all the panelists to be here. So coming back to the question, yes, of course, we have 2 types of RLS. That is, one we define as primary and the other is secondary. So it lies in the name. Primary means the cause is unknown. That is idiopathic, while secondary, it is associated with the other underlying conditions like we have already discussed. That is iron deficiency anemia. It can associate with chronic kidney diseases or like in pregnancy. So these are certain conditions in which you can find them. Second is the age of onset. Generally, the primary is generally in the younger age, that is like it occurs generally in age group less than 40 45 years, while secondary it occurs after 40 45 years. Mostly primary has been seen in males more commonly, but secondary is more common in females. Ethnicity has been seen not very much. There's not a lot of papers on that, but then it has been more seen primary in the dark skinned people. Secondary, there's not much link to the ethnicity. Obviously, there's a genetic predisposition in primary RLS, while in the secondary, there's not such predisposition has been seen. Most importantly, what is important to know is that in primary, the progression is slow, while in secondary, the progression is generally more severe, and so are the symptoms. In primary, generally, the symptoms are a little milder as compared to secondary RLS. And also, what we have been knowing in these conditions is that how we diagnose it. So, basically, in the primary cases, generally the sleep impact is little variable, while in secondary it is more severe. The sleep impaction is more severe. And the response to treatment, how we define in primary, because there is no underlying cause, so we have to treat symptomatically. While in secondary, the treatment has to be taken care depending on the cause of the underlying cause. Like if there is iron deficiency anemia, we have to treat that. If there is other kidney disease, we have to treat that. And so we have to diagnose accordingly. Thank you.
Fantastic, Dr. Gupta. I think she said it very well that primary is idiopathic, typically before 40, 45 years, and secondary is secondary to a cause, probably drug induced, and it affects above the age of 40 years, and the treatment depends on treating the underlying risk factor or removing the drug causing it. Yes, thank you very much. Saurabh, I know Singh sir told, but I want to hear from you. What is the pathophysiology of RLS? How does it happen? What are the neurochemicals or circuit disorders which we keep talking about which happen in RLS?
Yes, yes. So it was very well explained during the session, like by Dr. Singh. But if we want to summarize about the pathophysiology of rest leg syndrome, so it is basically multifactorial and very complex. So first mechanism, if we see, is dopaminergic dysfunction. So it is very strongly linked with the central dopaminergic system, especially in the substantia nigra and hypothalamus. So like we see dopamine agonist that improves the symptoms in the cases of RLS. And the key mechanism is what, like sir has explained already, likely involves dopamine D3 receptors, which leads to impaired inhibition of spinal motor pathways that leads to increased limb movements. Secondly, about the iron deficiency in the brain. So iron actually acts as a cofactor for the tyrosine hydroxylase enzyme, which is the rate limiting enzyme in the dopamine synthesis. So patients with RLS often have normal peripheral iron levels sometimes, but low brain iron concentrations. So particularly in the substantia nigra, thalamus and putamen part of the brain. So if you do MRI studies using iron sensitive sequences, we can see there's decreased brain iron in RLS patients. And then third comes the genetic factors. So genetic factors are very, very important. Strong familial aggregation we see in the early onset RLS. There are various genes which are identified, like MEIS1 linked to neurodevelopment and iron regulation, like BTBD9 gene, which is involved in motor control and brain development. So these are the three main mechanisms. Apart from that, there is a CNS hyperexcitability because of various factors. That is also important. And definitely serocardian influence is also there in the RLS patients.
Thank you, Saurabh. Very well said that yes, the dopamine and the iron are the culprits because iron is important precursor for the formation of L-dopa, and the deficiency of either or is going to cause a progression of RLS. There's also recent data and literature talking about the adenosine pathway and the alpha-1 receptors in the adenosine pathway, which is a potential stimulant and a hyperarousal state. So if there is a deficiency of the adenosine or the adenosine A1 receptor, it can potentially give rise to RLS, and therefore the future therapies and future targets of treating RLS are more focused into the adenosine pathway. So that's something which can also be linked potentially to the pathophysiology. BP Singh sir, asking you again, now Saurabh's mentioned the pathophysiology. This is for all our audience. What are the causes of RLS?
Really already mentioned by Dr. Ankita and Dr. Saurabh. This that RLS, we know that it can be primary, it can be secondary. Primary has already mentioned that we have idiopathic one, and where you do not know the cause, it may be the familial, you have genetic predisposition already, you have mentioned. And then secondary may be to the some factors which are responsible for causing this RLS. It may be this iron deficiency, which we all have been talking about. It may be because of the disease associated like the renal failure. The patient is having renal disease, having this RLS. In the patient of the pregnancy, pregnant female can also have this RLS. The other conditions may also be responsible, like some drugs if you are taking, they may be also causing the symptom of RLS, a disease like RLS, especially antihistaminics, antiemetics, antipsychotics, antidepressant. Lot many drugs are implicated in that way. Even those who are taking alcohol, caffeine, extra caffeine, and nicotine, they are also been related to the causing the secondary RLS. So this is how this restless leg syndrome can be produced by so many factors.
Thank you, sir. Another point which I'd like to enlighten our audience with is the association of ADHD and RLS. So we have a lot of children who've been diagnosed with RLS,
Yes.
and data tells us that about 30 to 40% of patients with ADHD have coexisting RLS, and about 20% of RLS patients do have ADHD. So there's a strong association between ADHD and RLS, and this is what we need to remember, that yes, it's a comorbid disease, a coexisting disease. So we must take into account the existence of ADHD, especially in a younger population, when we are calling them primary RLS. Satish sir, Singh sir has told us that there are some drugs which cause RLS. Can you enlighten us with all the possible drugs, because we use so many of them in our day-to-day practice, and which can potentially cause RLS?
Sure. I mean, Dr. Ankita was mentioning about secondary causes of RLS, which means that we have to look for a cause. And the most important causes are drug-induced. And we also mentioned about some caffeine and nicotine and so on. But, these drugs can aggravate an existing RLS or can also cause RLS. So that's why I think if we come across a patient with RLS, we have to first think about, is there any medication that patient is taking and which is causing an RLS or worsening of the RLS. And as mentioned, a whole lot of anti-psychiatric medicine. So I would say if somebody is on an antipsychotic or anti-psychiatric medication, many of us would not know what are these medication, but any medication that the patient is on, look for in the literature whether this can cause RLS, it can aggravate RLS. For example, antidepressants, mentioned in the literature, SSRI, SNRI, tricyclic, and mirtazapine, and so on, which, all of us know about it. Mirtazapine used sometimes as medication for depression and insomnia. So, including common drugs that all of us know is like fluoxetine, citalopram, and duloxetine, which is sometimes given as a medication for tricyclic, neuralgia, trigeminal neuralgia, and so on, including amitriptyline, which we all know as pulmonologists, non-psychiatrists, which we know. And the antipsychotics like olanzapine, which sometimes we use, even though we are not psychiatric, for an agitated patient, quetiapine, risperidone, and these also can cause and aggravate the problem. And anti-nausea medication, which was mentioned by Dr. Singh, like metoclopramide, and they have an effect on dopamine pathway, and that is why they are implicated in this. And there are, if you go on into the literature and see, for theoretical purpose, including thyroxine is mentioned, statins are mentioned, lithium is mentioned. So, in nutshell, I have any antipsychotic medication, difficult for us to remember in a day-to-day practice. Go through and see the checklist, see whether they give causing or they are aggravating an RLS. So drug-induced, basically. Thank you.
I think very well said, Satish sir. Two more important things is, one is a rebound effect and one is a withdrawal effect. So very often patients who are on benzodiazepines have a rebound effect of worsening of RLS, which we need to remember. So patients who are on sleeping tablets, a lot of them, the geriatric population. So the benzodiazepine withdrawal effect, or the benzodiazepine rebound effect rather, has a worsening of RLS. And alcohol withdrawal. Now we have data to tell that alcohol potentially can cause RLS, but alcohol withdrawal and opioid withdrawal itself can precipitate and trigger RLS. So rebound and withdrawal also needs to be remembered when we're dealing with patients who are dependent or alcohol addicts. Now,
Very, very important, especially alcohol withdrawal. Sometimes we tend to, say that it's a very non-specific symptom. Very well said. Thank you.
Thank you, sir. Sajitha, madam, can you please tell us the differential diagnosis of RLS? Now, what we need to exclude when we're looking at a patient and we're suspecting RLS?
That's very important. As Dr. Avya had earlier said, that it is that uncontrollable urge or uncontrollable sensation which propels the patient to movement. That is RLS. We have to differentiate it from a lot of other conditions. Like you may have patients, who have persons who have just volitional movements. They just do foot tapping or just do bouncing or leg rolling or something like that during their leisure time, and they are actually inactive, but actually they are not associated with, when you ask them, it is not associated with the this uncomfortable sensation. That sensory pathway is lacking in them, and they can voluntarily stop it. So that is how you differentiate it. So that is one thing we have to rule out. And second thing, sometimes some akathisia is a differential diagnosis, because patients who are on neuroleptic medication like venlafaxine, they may have that uncontrollable urge to get up, that sense of restlessness. But here also that unpleasant sensory sensation is not there. Only that inner urge to move, that is there. So that is how you can differentiate. Then some patients may tell you about painful nocturnal leg cramps, maybe due to some hypocalcemia, some conditions. But these are actually painful cramps, painful muscle contractions will be there. That is how you differentiate from the restlessness syndrome. And positional discomfort, some have especially the geriatric population, they have that uncontrollable urge to change their positions. But here also no sensory component of the restless leg syndrome is there. So that is how we can differentiate. And you also have to differentiate it from conditions which cause claudication pain in leg, like this neural claudication, vascular claudication, but these actually worsens with movement. That is how you can differentiate. And also the painful leg conditions, which is associated with spinal cord injury, spinal cord degenerative disorders or metastasis, etc., also has to be differentiated from that. But in all these conditions, it will be really painful, and associated reflexes will also be there. So this is how you can differentiate the usual conditions. And also you have to rule out the usual leg pain, leg edema, the patients who have venous stasis, arthritis. All this also have to be ruled out, but this you can easily rule out by clinical examination.
Very well said. I mean, in fact, just remember the pathies, the neuropathy, the radiculopathy, the myelopathy. These are something which needs to be ruled out. Patients with vitamin deficiency, B12 typically have the pins and needle sensation and often mistake it for RLS. That's something we need to consider. And claudication pain is very, very important. So very well said, Sajitha, madam. Now that we've understood the pathophysiology, the causes, the effect, the differential diagnosis of RLS, how do we treat it? That's the most important question. Everybody at the end of the day wants a solution to the problem. So, Dr. Gupta, tell me the non-pharmacological therapy of RLS, something which patients are averse to taking drugs. What can we tell them without medication, and how to control this important disease?
Thank you for the question. So first, most importantly, obviously we start the non-pharmacological is the diet. That is one thing what we have to take care is avoid the caffeine or the alcohol or the tobacco, which we have been studying that it can aggravate, even can cause the RLS. So, and especially in the evening time. So these things has to be avoided. Secondly, obviously, the exercise has been shown a lot of good role in a moderate exercise, especially in the morning or the afternoon time, not in the evening time. Avoid that, so that it helps in we can do the walking or the stretching exercises that can help in the reducing the symptoms. And thirdly, is what we need to understand is the sleep hygiene has to be maintained. That is, a consistent schedule has to be maintained. So with the correct environment, like the cool and dark and calm environment has to be taken care of, so that the patient has that relaxing environment to sleep. And fourthly, what we can do are certain things like to relax the muscles. One thing is the warm bath before sleeping. Secondly, is the leg massage can be done, or we can use the warm pads or cool packs, which can help to reduce the uncomfortable sensation in the legs. Something what we can add on to do is to do the cognitive distraction. That is, avoid activities like reading or watching something, doing yoga, mindfulness, which is very much upcoming. It can help to reduce the stress, which can improve symptoms in certain patients. What add-on can be done is the whenever the patient has that urge, the patient can do the certain movements like which can relieve the symptoms, can also avoid the triggers. Like if we know the underlying conditions like iron deficiency anemia is there or any underlying cause disease is there, we have to treat that. As told by B Singh sir, that we can there's something called high frequency peroneal nerve stimulation, which has shown certain conditional support as a therapy improving in certain patients. There's something more what we can do is the acupuncture. That it has variable response, but yes, it has shown certain improvement in certain patients. There's something called repetitive transcranial magnetic stimulation also, which is also a non-invasive brain stimulation that gives the magnetic pulses to stimulate specific areas of the brain, and has shown that if given in a high frequency, that is approximately in the 15 hertz or something, then it can improve the sleep quality and elevate associated anxiety with modulating the cortical excitability. Thank you.
I think very well said. And understanding the importance and the psychological impact of RLS is important. So, probably counseling, reducing the anxiety is going to have a positive effect. Taking care of drugs, opioids, caffeine, very important. Caffeine and tannin is something they need to keep under check. Sleep hygiene, which is so neglected, is very important. Peroneal nerve stimulation, yes. And counter stimulatory or counter vibratory massage therapies, like doing it in the opposite direction, is also shown to have a positive effect on the management of RLS. Now, moving on to the pharmacotherapy. So, Saurabh, what are the pharmacological management therapies in RLS? What drugs do we have? How do we manage it?
So if I can summarize, so first line therapy, like we prefer our alpha to delta calcium channel ligands like gabapentin, enacarbil, and pregabalin. So these are now first line therapy because see these all the molecules which modulate calcium channels and reduces the excitatory neurotransmission. So indication, this is one of the important indications. So all the gabapentin, like we have gabapentin since like 2011. So only thing with the gabapentin is renal dose we had to calculate. We can't give like higher doses in renal patients. And gabapentin enacarbil is the FDA approved drug. 600 milligram is the dose. Pre-GABA we can give 75 to 300 milligram. And these are the first line drugs. And the second, we prefer the dopaminergic agents, like we have already discussed about three molecules, pramipexole, ropinirole, and rotigotine. So these molecules like pramipexole and ropinirole have come in 2005 and 6 since we are using. The ropinirole we use in Parkinsonism also. So this is the common drug between Parkinson and RLS. And the dose is also a maximum dose we can use 4 milligram. Already Dr. Singh sir has discussed in their slides in details. Rotigotine is basically a patch. Highest we can give around 3 milligram in a day. So these are the molecules, and then comes the iron supplementation, which is very, very important. So if the serum ferritin levels are low, less than 100 or 75, or low transferrin saturation is there, so then we prefer oral iron, that is ferrous sulfate 325 milligram twice a day. And the IV iron, if you are choosing, the best option is ferric carboxymaltose that can be given 1 gram stat dose. That is also very, very helpful in the patients. And along with that, we have discussed about the low dose opioids like methadone, which is like widely used in the Western population. Tramadol, other opioids also which can be used. Benzodiazepine also, Dr. Satish has discussed. Clonazepam, temazepam, these molecules are also there as a But the main core of therapy, if you ask me, is the alpha to gamma ligands, delta ligands, that is gabapentin, and then comes the dopa agonist, and then iron supplementation.
Well said. What our audience also needs to understand is the maximum dose of gabapentin nagabil is about 1200 milligram per day. Pregabalin, we can go up to 400.
300 to 400, yes.
Yes, and
450.
450. And
450.
pure gabapentin can be given up to 2400. So we need to understand that starting at suboptimal and low doses of 75 milligrams of pregabalin or 300 milligrams of gabapentin may not have the desired effect, and we should not be
Yes.
scared, and a dose should be titrated. Also, opioids
Yes.
have been recommended by the JCM for the management of uncontrolled or refractory RLS. So, conditional recommendation of opioids has also been given. We need to be careful. We need to consult a psychiatrist ideally before we start a narcotic in these patients, or a neurologist. That has helped control refractory cases of RLS. And the most important drug which works in RLS is a placebo. So very often there
Yes.
is an anxiety component which is there. So we must not forget that placebo becomes an extremely important drug to control and manage RLS, and we should give that importance. Probably take the primary caregiver or the family member before we start the placebo to get back to us in a couple of weeks, because that's the time a psychological anxiety component could be relieved. And if the severity of the RLS comes down, then probably a low dose pregabalin or gabapentin can work in these patients.
And
So
one
thank
more
you,
thing,
Saurabh.
Dr. Avya, one more
Yeah.
thing about the augmentation.
Yeah.
During the augmentation, we have to switch from the dopaminergic agent towards the pre-GABA if patient
Yes.
is on both treatment. So slowly gradually we have to reduce the dose of dopaminergics, and slowly we have to increase the dose of pre-GABA or gabapentin.
I
So
think
that
because
is
of
the
the
way.
worry, I think because of the worry of the augmentation, we've slowly moved away from the dopa pathway drugs.
Yes,
We've gone towards the pregabalin, gabapentins of the world, and we've started considering non-pharmacotherapy, placebos, and opioids. And also, like
exactly.
earlier said, we've now there's enough data, and the new molecules which are undergoing testing are on the adenosine pathway. So the alpha
Yes.
1 or A1 adenosine pathway is a potential game changer for hyperarousable state. So probably we may have exciting drugs in future. So time will tell us. Moving on to Singh sir. So once again, now we've covered RLS. Now we're going to hit you again with PLMD and make you repeat everything. So what is PLMD and what is the incidence of PLMD for our audience, sir?
Dr. Avya, already, although we have presented this in our slides,
Yes.
that periodic leg movements are the condition where you have episodes of simple repetitive muscle movements. This is what the PLMD is, periodic leg movement disorder. And for the diagnosis, you know that the sleep study has to be done. And there you can identify that this patient is having PLMD. And the criteria, as already mentioned, it should be more than 15 per hour in adults and more than 5 in children. It can happen during sleep most of the time, although it can happen in the awakened state also. But it is much more relevant during sleep. Why it is important in sleep? That during sleep, patient may not be aware of this PLMD, and patient may be having excessive uh, fatigue during the day and also the increase in sleepiness. So in that way, this can happen with the patient. Patient may not be identified. Somebody else has to, our partner, bed partner has to tell that this patient is having the PLMD. And if you look at the incidence of it, then if you look at the data, that it is accounted around 5 to 8% in children. In adults, although it is around 4 to 11%. Studies have shown. As the age advances, the incidence increases. And few of the studies have shown in more than 65 years of age, it is around 40 to 50%. So that is how the incidence is going up with the advancing age.
Very well said, sir. And we should also remember when we are reporting a sleep report, the PLMS or the PLMD component at the bottom of the report should not be neglected. Very often, our eyes only go to the
Yes.
RDI and the oxygen desaturation,
Yes.
and PLMS is something which is ignored. When patients would often have complaints, their spouse would say that snoring is an issue, yes, but he or she is often kicking us or moving the legs too much. So that also becomes an important issue for us to address. So making a note of that little small red remark at the bottom of a sleep report helps us. Satish sir, We've understood the pathophysiology of RLS. How does it differ in PLMS? What is the pathophysiology of PLMS?
So, as Dr. Singh showed beautifully in his slide about the different pathways, and you were also mentioning about the adenosine pathways. So, we are learning about it more and more, research going on to it. It's still not fully understood, even though there are hypotheses, but several key factors and mechanisms have been identified, mainly of central origin, and most of it has got to do with the dopaminergic pathway, as we saw many of the drugs which causes or aggravate restless leg syndrome. Here also the dopaminergic pathway is one of the main pathway which is blamed, and any abnormal or dysregulation of dopaminergic pathway can lead to PLMS, and which is supported by many evidences, including, for example, patients, Bansal, who has Parkinsonism, tend to have a more incidence of PLMS. And that's where you can see that there is a deficiency of the dopamine factor and dopamine, and causing this kind of. So that is an indirect way of saying that there is definitely a dopaminergic pathway which is involved. And we also talked about iron deficiency, ferritin involvement, and the treatment of all that. And Dr. Singh was mentioning the new guidelines. So that comes to mind whenever you think about the pathophysiology, that the iron levels, especially low ferritin levels, are important and linked to PMLD symptoms and the restless leg syndrome. Both are, kind of similar. One is involuntary, one is voluntary. So that's the difference. And as I think also, mentioned here in the discussion about the iron as a cofactor, which is important in the synthesis of dopamine. That's also an important thing to consider. And also we mentioned about some of the genetic factors, which is also important in causation of PLMDs. And we also mentioned about various etiology, the pregnancy, the card injury, and all that. There's some connection between all this and leading to this kind of pathophysiological status of PMLS. So I would summarize here, it's a combination of genetic predisposition in an individual, in a susceptible person, and dysregulation or abnormal dopaminergic transmission, neurotransmission, and a factor like iron and ferritin contributing to this, causing a central as well as a spinal reflex. Is a little bit of a complex pathophysiology, never fully understood, but we are, there for the pathophysiology. Yeah, thanks.
Very similar to the RLS, but yes, more to learn, more to understand. Still a lot of in-depth analysis and a lot of importance to sleep medicine has to be given. Thank you, sir. Sajitha, madam, what are the risk factors or the causes of PLMD? We've heard about the pathophysiology, the incidence, what it is. What are the risk factors which can contribute and we should suspect PLMD in a patient with?
Actually, most of it overlaps with what Dr. Satish has already said. That is, patients with iron deficiency is more at a risk. But what we have to understand is restless leg syndrome and PLMD are mutually disclosive. Actually, though the RLS symptoms can have, most of the 80% can have periodic limb movements, this periodic limb disorder itself is actually mutually exclusive, and that is always associated with the sleep dysfunction. So that is, but the etiology is somewhat similar. That is, the patients with people with iron deficiency are more prone to that. And we also know patients with diabetes, chronic kidney diseases, then obesity, hypertensives, they also seem to have an association with this. But what we have to understand is this periodic limb movements is also common in children. It is very closely associated with ADHD. And it is very common. Actually, they both coexist. RLS and PMD coexist in ADHD children. And also what we do need to know that this also has to be differentiated from the periodic limb movements which occur in due to consumption of antidepressants and all the drugs. They also have this periodic limb movements. And Parkinsonism, that is very well associated with that, obviously due to the decreased dopaminergic pathway. But periodic limb disorder as such is an exclusive entity when not associated with all this, but it has an association with obesity, CKD, iron deficiency, and the disorders we discussed above.
Very well said, ma'am. And also, we must remember that obstructive sleep apnea is an important entity which itself becomes an independent risk factor for the development of PLMD and RLS. So, OSA, yes, let's not forget the good old OSA, that's equally important. Dr. Gupta, we've heard about PLMS. What is the diagnostic criteria? Sir said that the score should be above 15 in adults and above 5 in children. But what do we mean by the periodic limb movement? What is it actually? How do we define it?
Thank you for the question. Yes. So when we are making a diagnostic criteria, so the 5 points are important. So firstly, what we mean by periodic limb movement? So it is basically a stereotypic movement of the limbs, and it involves dorsiflexion of the toes and ankles, and occasionally flexions of the hip and the knee joints. And it occurs in the cluster of more than 4 consecutive movements. Now, what is more important is what is the number. So we talk about periodic limb movements during sleep index. So that is what should be more than 15 in an hour in adults, and while in children it should be more than 5. And it should be associated with the significant sleep disruption and can be associated with the daytime impairment. Like there can be daytime sleepiness, there can be fatigue, the patient has loss of concentration, so that can be associated with that. And here we can diagnose by polysomnographic. So there should be polysomnographic confirmation with that. And how we define that? It has to be a periodic limb movement that should be during non-REM sleep. And with typical movements, they should be lasting, the duration should be 5 to 10 seconds. And with the interval of 5 to 9 second interval, as being said. And more importantly, the other sleep disorders need to be ruled out, like restless leg syndrome, because 80% of RLS can be associated with PLMD. So we have to rule out first that obstructive sleep apnea, any REM sleep behavioral disorders, or any narcolepsy. And to understand the cause, we have to have a proper detailed history and examination of the patient to know whether any secondary causes are there, like iron deficiency anemia or other neurological disorders, as has been explained before. Thank you.
Very well, sir. Also, we need to emphasize again and stress on the importance of a level 1 polysomnography, because PLMD is often underreported in the level 2. Let's forget level 3 and level 4. So PLMD, if you want an accurate severity of PLMD, a level 1 polysomnography or a video polysomnography is very, very important for us to accurately score it. And repetitive spurts of 0.5 to 10 seconds occurring every 5 to 90 seconds is what we consider to be PLMD. And I also feel that the more we go towards a level 1 polysomnography, the incidence of PLMD is going to increase and the underreporting will stop. That's just
very true.
Yes. Saurabh, what are the differential diagnoses for PLMD? I mean, we've understood PLMD, but how do we exclude it? What should we keep in mind when we're suspecting PLMD?
So differential diagnosis, if you ask me, so first is like we have discussed restless leg syndrome. So key features and how to differentiate, if we see there is a urge to move limbs before sleep onset. Okay, so and voluntary relief patient get by movements. So PLMS often coexists, but not same as PLMD. And second is obstructive sleep apnea. So there is apnea related basically arousals that can trigger PLMS. If limb movement resolves with your CPAP or secondary PLMS, so that is not PLMD. So that we need to see. There is another entity which is REM sleep behavior disorder, that is RBD. So which is very vigorous, purposeful movements during REM sleep, particularly associated with dreams. So polysomnography can show this REM, we can identify this REM sleep behavior disorder. There is a sleep-related rhythmic movement disorder. So mostly this is in children. and that is after injury. That is, these are the rhythmic movements, but not periodic. And there is another entity which is called nocturnal seizures or nocturnal epilepsy, which is also very abrupt, stereotype movements. Often, like this is a very rapid limb jerks. So we can do EEG and we can check about this whether it is seizures or not. And medication also, like we have discussed, there are different medications sometimes people use, like SSRI, tricyclic antidepressants, antipsychotics, that can also trigger PLMS. So if it is medication related, it is not true PLMD. And it could be in elderly people, it could be a normal variant also. PLMS increases with the age actually. And asymptomatic in many cases, which is not pathological. And unless until like these things are disrupting the sleep. And other entities, DD, if you ask me, narcolepsy, hypersomnia disorders, these also PLMS may present, but not primary cause of sleeplessness. So diagnosis based on in those cases we can go for MSLT and cataplexy and all we can see. And last DD, if you ask me, the like spinal cord pathologies may cause like limb jerks during sleep. So that is another DD which can mimic the PLMD.
I think very well said. Also, leg cramps, something which we commonly see. Leg cramps can be a very important differential diagnosis for PLMS, and patients who have alternating leg muscle activation because of the anterior tibialis muscle do also suffer from proper differential diagnosis need to be kept when we're looking at ALMA as well as leg cramps. So thank you, Saurabh. Very well said. Singh sir, what is the treatment of PLMD? How do we treat periodic limb movement disorder?
As already mentioned in our presentation, that treatment of PLMS is basically, it may be non-pharmacological and pharmacological. In the non-pharmacological treatment, the most important thing is the sleep hygiene. We should be able to maintain the good sleep hygiene to control over the disease. We should have a good physical activity, the exercise then can be used, and you avoid things like nicotine, alcohol, and basically caffeine, so that you should not have stimulation at night, and you should not have this periodic movement. One non-pharmacological therapy which has also been described is the weighted blanket. You can use it so that it can suppress the leg and you will not have this periodic leg movement. In the pharmacological treatment, the most important has already been mentioned. There's alpha to delta ligand. This is basically gabapentin or pregabalin. You can use the dopaminergic agents like ropinol or pamiprexel or the retroguetine. So all these drugs can be used. And most importantly, apart from that, is the iron supplement. If the iron deficiency is there, that needs to be used in your patient for the management. This is how you are going to treat pharmacologically these patients. And you should also have consideration about that. If their patient is having any underlying condition, that should also be treated effectively to have a proper control of the disease.
Very well said, sir. What we also need to remember is very often we co-diagnose it with our OSA. So we must also look at, once we correct the sleep apnea, whether the PLM index gets better or it doesn't get better. The drugs mentioned by sir are very, very important. Also, circadian rhythm has been associated with PLMS. So there is some role of melatonin, which has shown to improve the PLM index. So probably a very low dose of 3 mg 30 to 60 minutes prior to bedtime does help. And in refractory cases, there's been some data on clonazepam to be helpful in these patients. Yes, all these drugs do work, but again, I'd like to put my emphasis on another very, very important drug, which is a placebo. So placebos should be considered, given a shot. They work well, they help reduce anxiety. Yes, gabapentin, pregabalin can be given, but once you correct your OSA, in a case of coexisting OSA and PLMS, and the patient still complains, or the relative complains about, the spouse complains about the leg movement, maybe a low dose placebo could help in these cases. Now, thanks to my wonderful panelists and speaker, we've understood the nitty-gritties of PLM and RLS. But why is it important? What is the prognosis of RLS and PLMS, and what are the complications of these two disorders? Satish sir, can you tell us why is it important and what are the complications of them?
Absolutely. And why do we pay attention? Why do we diagnose? Why do you mention that, level 1 or level 2 is important, not level 3? Is because if you see the evidence, PLMI of more than 15 is itself an independent cause for mortality, is an independent factor for mortality. Leave alone for adjusting age, sex, then sleep efficiency, and so on. So there is a increased mortality risk related to. It's generally related to cardiovascular and sympathetic nervous system activity, which is linked to PLMDI. So that's why it's important that we pay attention to PLMD as a prognosis. So it all depends on, as you said, that sometimes placebos work. There are drugs which are important. So the prognosis depends upon that. So it's a chronic condition. Often the symptoms fluctuate. Sometimes they come and say that they are better, and where placebo works, and if it is associated with sleep apnea, treating sleep apnea, sleep hygiene, all those medication that you mentioned also help. But it's not like you're looking for a cure. It's looking to improve symptoms and quality of life. So any increase of PLMI of more than 15 is associated with higher all-cause mortality risk, independent of these sleep disturbances that I mentioned. So prognosis really, Bansal, depends on outcomes, depend on severity, comorbidity, response to treatment, and so on. That's why prognostication is important, and identifying and treating that appropriately is important. This is about the prognosis.
Very well said, sir. So RLS and PLMS should not be ignored. It should be treated, firstly diagnosed and treated correctly. Because also what we need to remember is RLS and PLMS have got a sympathetic overdrive. So there's a dysregulation between the sympathetic and the parasympathetic activity. As a result, there's a documented evidence of increased cardiac mortality and morbidity in patients with RLS and PLMS. So whenever some patient or anybody argues with you, just tell them blame it on the heart. So the minute you start talking about the heart and the heart being a risk factor, automatically their senses are like, okay, this needs to be corrected because apparently heart is the only organ and the most important organ. Lungs are secondary. So even when we talk about sleep apnea and CPAP, we often use hypertension and cardiovascular risk factors to convince the patient to go on the CPAP therapy. Similarly, we must convince them and tell them that yes, cardiac activity, ischemic heart disease are known risk factors if RLS and PLMS is uncorrected. So thank you, Satish sir. Now, Sajitha madam, are RLS and PLMS two sides of the same coin? What are the similarities between these two diseases?
Okay, thank you for that wonderful question. So yes, both we should actually what we should understand is they both have the similar pathophysiology and a similar actually etiology. But RLMS is a purely clinical diagnosis. That is, it is you can just diagnose it clinically, and though it is associated with PLMS, periodic limb movements, but it is an entity of its own, and that can be clinically diagnosed and treated on its own. But PLMD is actually, it affects your sleep function, and so it is always associated with that hypersomnolence and sleep inactivity and increased daytime sleepiness. So that has to be diagnosed with polysomnography. That is the main difference. But on the other hand, when you consider the pathophysiology and etiology, both of them have similar. And on treatment front also, you actually the treatment is quite similar. As we have already mentioned, the iron supplementation helps. The treatment of underlying conditions help, and are definitely the pregabalin and gabapentin help, and dopaminergic agents help in both. So in that way, both of them are there is similarity in them. And also the treatment, the management of airway during sleep in both PLMD. Along with that, this restless syndrome also, it's always better to evaluate them for this PLMS because they can have airway dysfunctions, and the treatment of OSA may also be important. So actually, in the treatment front, in the etiological area, we have similarities. So in both conditions, though the clinical diagnosis and diagnosis is different, there are very important similarities. And the cardiological risk, because of this association of RLS with periodic limb movements, that 80% people are associated with this risk factor is also there for RLS, a lot, just like the periodic limb disorder. But all periodic limb movement disorder do not have this restless leg syndrome. So that we have to know, and we can diagnose it only by polysomnography. So in this fronts, both are similar, and the treatment they have to be addressed. I mean, they have to be considered as the sides of the same coin, I think.
So both have limb movement disorders, both have the same almost similar pathophysiology of low iron and dopamine being the culprit, and both essentially require the same treatment with pregabalin, gabapentin, and probably opioids can be considered at some stage in life with placebos and sleep hygiene and OSA treatment. And also, both of them have associated sleep disordered breathing. They give rise to sleep fatigue, sleep hygiene is poor, and daytime somnolence is something we see very similarly in patients with RLS and PLMD. Very often, we have patients who come to us with daytime sleepiness and they may have a normal polysomnography, but ultimately, the PLMND or the PLMI would be very, very high. So, that could be contributing to the daytime somnolence and daytime fatigue because the quality of sleep has been impacted severely because the constant leg movement and the overdrive of the sympathetic activity at night. Now, if they're actually same, Dr. Ankita, is there any difference between the two?
So basically, these are the two disorders which have similarities also, but they are still different. They are two entities because what we understand is restless leg syndrome. The patient is awake. So patient is awake, and generally the symptoms they occur in the evening during the rest time or during the inactivity. While the periodic limb movement classically occur during the sleep, the patient is basically unaware, and it's generally it is basically what we understand is restless leg syndrome occurred during the consciousness of the patient. The patient is conscious enough, and periodic limb movement patient is obviously not conscious at that time. Secondly, the movements in the restless leg syndrome are voluntary. Basically, there's an unpleasant urge to move the legs, and therefore it is get relieved by making a movement. While in the periodic limb movement, it is an involuntary rhythmic limb movement that occurs during the sleep. And restless leg syndrome, we generally diagnose it by clinical criteria only, depending on the patient's symptomology. While periodic limb movement classically require polysomnography, where we have to identify the number of periodic limb movement in an hour, as defined that it should be more than 15 in adults, and in children should be more than 5. And those are rhythmic stereotypic movements of the dorsiflexion of the toes and the ankle, hip, and knees and hip. What other thing we can understand is that the exactly movement as we have talked about, the in periodic limb movement is repetitive jerking, twitching movement, while in the restless leg syndrome, there's basically it starts with the urge, relieved by the movement or any movement which has to be done. Then the second thing is that in restless leg syndrome, the patient has difficulty in falling asleep, so there is insomnia. While in the periodic limb movement, patient has fragmented sleep. Patient sleeps, then he starts having a movement, and the patient gets disturbed sleep. So there's the fragmentation. Obviously, there is some overlap as being told by Dr. Sajitha. So what is the similarities? But we know that they can occur together in 80% of people, but not all PMD can have the RLS. And what else we can understand is that the causes is almost similar. So that has been already told. The treatment is also almost similar. So there's not the difference. Only thing is what we understand is the consciousness and the unconsciousness where it majorly differs, and the movements what we are talking about. Thank you.
Very well said, Dr. Gupta, about the differences between the two. Also, we all have said multiple times that a polysomnography is not important for the diagnosis of RLS. But what is the actual polysomnography finding in RLS which differentiates it from PLMS is that RLS predominantly would be an REM spurge, where we have more REM involvement in the sleep and less of stage 1, whereas a PLMI is more of an NREM involvement. So that's another key factor when we are looking or interpreting a polysomnography report, which is why the video polysomnography becomes so very important. That it helps us understand that yes, this is more of an REM versus an NREM predominant limb movement disorder.
Definitely.
Now, after having discussed all of these things, I'm going to ask two burning questions or two very, very important questions, which I personally feel the entire audience wants to know. And that's the only reason why they've understood or taken part in this webinar is I'm going to ask Saurabh is, Saurabh, what is the impact of OSA or sleep disordered breathing on RLS and PLMS? This is something which all of us wants to know, because predominant sleep practice for pulmonologists is OSA and revolves around obstructive sleep apnea. So what does sleep disordered breathing have a role or a play in RLS and PLMS? How does it affect it?
Yeah, so impact of sleep disorder breathing, or OSA, what we call, on RLS and PLMD is very clinically important, because these things are often coexist and interact also. So sleep fragmentation, if we call sleep fragmentation, it worsens RLS and PLMS. So apnea can cause repeated arousals, which can intensify your RLS symptoms and increase the number of PLMS also. So sleep fragmentation leads to greater awareness of limb discomfort, that you can say, worsening the urge to move the in RLS. So and second thing, the shared pathophysiological mechanism, that is also dopaminergic dysfunction and iron metabolism abnormalities, are common in all three conditions, whether it is RLS, PLMD, or OSA. So chronic intermittent hypoxia from sleep disordered breathing may disrupt dopamine pathways and worsening the limb movement symptoms. And sleep disordered breathing can mimic or mask PLMS sometimes. But once you treat OSA with the CPAP, true PLMS may become unmasked in those cases. And CPAP improves PLMS in many patients, but not all. So treating OSA with CPAP reduces sleep fragmentation, which can decrease PLMS and improve RLS symptoms. If you ask me one word, like it worsens basically the impact of SDB, its sleep fragmentation worsens our RLS and PLMS both.
Very well said, Saurabh. I completely agree with you. In fact, even the American Academy of Sleep Medicine has postulated that nocturnal hypoxia in the legs has been associated with worsening of RLS. So, sleep disordered breathing essentially causes nocturnal desaturation and nocturnal hypoxia. And the longer the nocturnal hypoxia and the nocturnal desaturation, the worse would be the RLS or the PLMS, which is why whenever we have patients with severe sleep apnea, we often see that PLMI going above 15, whereas patients with mild or moderate OSA generally may have a normal PLMI if PLMI is because of the OSA itself. So yes, nocturnal hypoxia or leg hypoxia becomes very important. BP Singh sir, the other question to you. What is the impact of RLS or PLMS on sleep disordered breathing?
Although Dr. Saurabh has already mentioned, both things are almost similar. If you look at the RLS, actually there is a urge to move the leg and there is a disturbance while you are going to sleep. So there may be difficulty in the initiation of the sleep, first thing, which is very important. That may aggravate the symptoms of anxiety, even the psychosis and all these things. And also, it may be important for, as you all know and already you have mentioned, that increases the sympathetic stimulation and sympathetic surge. And that is also responsible for disruption of the sleep and also increase in the cardiovascular events in these patients. And the similarly with the periodic leg movement, this also causes it causes arousals, it causes increased sympathetic activity, and also the cardiovascular morbidity and mortality. So in that way, both of these situations can have an adverse effect on the sleep disorder breathing and having prognostic effect. Patient with a periodic leg movement might have increased daytime fatigue while not knowing, even having a good CPAP treatment, they may not be relieved in their symptoms and they may not be aware of the periodic leg movement disorder that they are having and causing extra fatigue in the daytime. So all these can disrupt the patient's quality of life. And simultaneously, as already mentioned, the patient with the RLS, they may not be a good compliant with the CPAP because of the RLS only. So they may be having a poor compliance. So in that way, RLS and the periodic leg movement disorder, they both have a significant effect over the sleep disorder breathing, especially the obstructive sleep apnea, affecting the efficacy of the treatment and the outcome.
Very well said, sir. Very, very well said. Because daytime sleepiness, daytime fatigue is often something which is worsened by an underlying RLS and PLMI. And although we may see a compliance report of patients on PAP therapy and we have an RTI or an AHI less than 5, but yet they are symptomatic. So that's the time we probably need to find out and chase and understand whether we have a coexisting RLS or a PLMI, which is contributing to sleep fragmentation, daytime sleepiness, and daytime fatigue. So RLS and PLMS is not that rare. We've heard our esteemed panelists and speakers talk about it and tell us that yes, it's as high as 20% in our population. And it's not something which should be left at the end of the book or a chapter, which is just as a reference reading for a Viva question or an exam question. It does exist in our clinical practice and should be taken seriously. And we must give it its due diligence and importance. After having this wonderful discussion, I've got a barrage of questions from our engaging audience with almost 2,600 logins. That's a fantastic number. And I'm going to ask my panelists to please enlighten everybody once again, even at the cost of being repetitive. So I'm going to start with Dr. Satish, sir. We've got the first question from Dr. Hiral, that any biomarker for the diagnosis of RLS and PLMS, sir?
Not really. I think we discussed about it. Dr. Sajitha mentioned, Ankita mentioned, and Dr. Singh, that for RLS, it's clinical. It's a symptomatic, and patient's story will tell us, symptoms will tell us that it is an RLS. And it's, as you mentioned, not to ignore the last part of the sleep study report, and to look for, the restless leg and those kind of things. And when patients have symptoms, they should also look for any aggravating, any cause like drugs and so on. So there are no real biomarker. If you consider a surrogate marker, like for PLMS, doing a sleep study, a good sleep study will tell us about, and a good history will tell us about patients having RLS or a PLMS. There are no biomarker. One marker which will tell us, okay, this is RLS, this is PML. I think it's a combination of history and then some of these diagnostic sleep studies which will tell us.
So very, very interesting, sir, because she also has a follow-up question that what is the role of TRP and IL-6 markers in RLS diagnosis? So your thoughts on that, sir?
Absolutely no value in doing. And if somebody with RLS or a PLMS has an elevated IL-4 or a CRP level, it's due to something else, not due to this. And there are no markers, as I know, which will tell us that this is, RLS and PLMS.
So I probably know why she's asking this question. Dr. Hira is asking this question is probably there's association between IL-6. IL-6 is a marker of inflammation. RLS has inflammation. So yes, it can be associated, but does not define it. Similarly, there's a lot of work on N-wave frequency, and we've got NFL, that's the neurofilament light chains. There's a lot of research going on. There's a research going on glycans and metabolomics for the potential association with RLS, but no definite concrete marker. And I completely agree. I would not chase it unless we've got enough data to say otherwise.
And we mentioned, Bansal, about the genetic mutation or genetic, things. So if you want to really go into the research and find out, then there are markers like genetic mutation. There are very specific one mentioned in the literature.
So probably a whole genomic sequencing rather than the TRP6 and an IL-6 levels would make more sense. Yes, I agree with you. Sajitha, madam, we have Dr. Hiren Popat from Vadodara. Is it possible, in a possible RLS, if an iron deficiency is documented and treated, and the stop bank questionnaire is less than 3, is a polysomnography still required in this patient?
That would be a very interesting question, because RLS, we know that it is usually associated with periodically movements. But if the iron deficiency is actually documented, it is being treated, and if there are no actually predisposing factors, then there is no absolute requirement for a PST. But if the patient has associated sleep, increased sleepiness, mostly some patients are associated with the increased sleepiness, etc. Only if the stop bank is actually indicative of a sleep disorder breathing, a PST is mandatory for the patient to disorder that. Otherwise, per se, it is not actually recommended for all the patients.
I agree with you. Also, we need to understand whether the RLS is controlled with the iron supplementation or not. If the RLS is not controlled with the RLS supplementation and you're suspecting that there is a concomitant PLMI or an OSA component, even though the stop bank is less than 3, you could do a polysomnography, because not just OSA, but even nocturnal hypoxia is a risk factor for the RLS. So sometimes nocturnal hypoxia should be diagnosed in patients, especially with chronic respiratory and chronic cardiac issues.
Exactly. So a follow-up of patient is required after the treatment.
Absolutely. So Dr. Neerav Gandolia from Surat is asking that neurophysicians are preferring iron supplementation to pramipexole more. So Dr. Ankita, any reason? I think sir has told this multiple times, but I want you to elaborate it once again why iron supplementation is more important than pramipexole.
So basically, it has been shown that the main issue is the iron deficiency, which is causing the symptoms at the brain level. So the first most and foremost is if we detect that there is this deficiency, it is better to give this drug than going to the other drugs as advised. And that also pregabalin, gabapentin, those are the other drugs which have been shown as the more preference than the other drugs. But still, there is the iron because that is causing the deficiency in the ferritin level, the low ferritin level. We will first correct that. So we have to correct the underlying mechanism to first correct that. And if after that also the patient is refractory to it, then we can give the add-on drugs.
The dopamine supplementation or drugs acting on the dopamine pathway aren't really going to work and help unless the iron stores which are depleted are corrected. The ferritin hepcidin levels should be normalized. And the reason why people are preferring iron supplementation and pregabalin gabapentin is because of the reason of augmentation and rebound. So Dr. Vishwesh has that question that what is augmentation and rebound, and why these drugs such as pramipexole or propranolol are fading away. So Dr. Saurabh, can you take up that question once again? You'll have to unmute, Saurabh. Sorry.
Yes. So augmentation is basically a paradoxical worsening of RLS symptoms, which is caused by long-term use of dopaminergic drugs. So that is called augmentation. Whereas what is rebound? Rebound refers to return of RLS symptoms later, like later at night or early morning. Okay, as the effect of single evening dose of medication probably. So rebound is a thing which is not mechanism is different. So in the augmentation, we are using dopaminergic agonist, but rebound, when we tell, rebound means the one drug we have given and again morning we are seeing the symptom, or later part of the night we are seeing the symptom, that is the rebound.
So when we look at cause and effect, the cause for augmentation is the dopamine agonist, and the cause for rebound with respect to therapy are opioids. So if you've probably given a very low dose opioid to the patient for the treatment of RLS, once the drug has a wearing off effect, the patient may have a rebound of symptoms. And when we look at rebound as a cause of PLMI and RLS, it would be the alcohol withdrawal would be probably the cause of the rebound. So understanding the cause and effect of rebound becomes very important. BP Singh sir, a very interesting question by Dr. Mohan from Karnataka, that the dopaminergic system of RLS has any relation to Parkinson's and any prediction for both of them coexisting with each other?
Yes, actually, both are involving the similar pathway, and that is why the drug like roperidone has effect on the RLS also and in the Parkinson's treatment also. So both are interconnected in some way, and these therapy which are affecting the dopamine, they are affecting both the diseases. So I think that is the reason we are using it.
Absolutely, sir. So the treatment of, it's very rare for us to find patients with underlying Parkinson's develop RLS because these patients are already on therapy, and if they actually end up developing RLS, then probably gabapentin or pregabalin would be the go-to drug in these patients, or optimizing the therapy for Parkinson's would be the first thing. Now, Satish, I'm going to ask you a very tricky and an important question which Dr. Jaykishan sir from Punjab has asked us. That should a pulmonologist consult a psychiatrist before prescribing a narcotic or habit-forming drug in PLM without a polysomnography?
That's for me?
Yes, sir, that's for you.
Okay.
All the tough ones are for you, sir.
Yeah, good question. Yeah. I mean, I suppose yes, because it's a very complex medication which we don't use regularly. If it is simple clonazepam, pregabalin, gabapentin, I'm okay with that, absolutely no problem. Or a short term giving a mirtazepam or those kind of things, or patient having restless agitation, then giving a olanzapam, those kind of things are okay. But if you're giving a complex drug, an antipsychotic, antidepressant for a long term, and I think better to, consult a psychiatrist. I would certainly ask my colleague psychiatrists to have a look at it and then prescribe these drugs. And many of them have drug interactions. So, and these patients are on multiple polypharmacy. So one has to be very careful. So I definitely, I would consider and consulting a psychiatrist, take his opinion and then prescribe that.
No, very well said that we must not have a closed approach that if a patient has come to us with an RLS and PLMI and we are not confident in dealing with narcotics, there's no harm in referring the patient to our colleague, because at the end of the day, we both want what's best for our patient, that the symptomatology should be under control. So that's extremely important.
Well said.
Yeah. Dr. Sajitha, how do you differentiate PLMS from other movement disorders or sleep fragmentation from comorbidities? That's a question by Dr. Smita Patil from Bombay.
Actually, by other movement disorder, I presume that you mean Parkinsonism-like disease, movement disorders, the neurodegenerative disorders. So obviously, they have the other clinical features which differentiates, and this PLMS is associated with other the movement disorders also. But obviously, they'll have the clinical features associated with that tremors, your all the other symptoms of Parkinsonism. But apart from all this, your polysomnography is very important, because sleep fragmentation due to other comorbidities can be differentiated very well by this, because the PLMD and PLMS, we know that actually it's a disease of the NREM sleep, and it onset occurs at the first stage, at the second stage, and you classically identify it by this duration of this movement along with the frequency with which I mean how long it lasts, and also the amplitude of the waves. So there is specific polysomnographic criteria for identifying the periodic movements by polysomnography. Along with that, you can also actually have a talk with the bed partner, which will tell you the actually exact onset of the leg movements. That is also will help you to diagnose. So along with this, you have the clinical diagnosis of other neurodegenerative disorders. The symptoms will help you. Polysomnography will help you the exact amplitude and onset of duration. And also the your description, your bed partner's description also will help you.
We've often had patients complain that they have different beds and different rooms because they can't tolerate the partner snoring. But we also see a lot of patients sleep separately because they can't tolerate the partner's leg movement or leg kicking. So it's an equally important history to be taken from the partner. We often just ask about snoring and we don't talk about leg movement or leg kicking, which happens in the night, which could be an important marker for PLMI, which is there. So something very similar to that, Dr. Gupta, I want to ask you, which Dr. Asha from Delhi coincidentally asked us, is that how do we distinguish neuropathy and nocturnal leg cramps from RLS? Ma'am, you'll have to unmute yourself.
Distinguish?
Neuropathy and leg cramps from RLS, yes.
Okay. So we're talking about neuropathy. So basically, we have to understand first the history. Obviously, starting with the history, it's more important what the patient is saying. And therefore, the RLS will have the patient will have the conscious awareness of the urge of sensation in the legs, and where then it get relieved with the movement. So that is what the patient felt. Cramps basically, again, clinically, we understand that cramps can be because patient might have any strenuous activity before that, and patient there is muscle stiffness is there. We get relief simply by some we can give muscle relaxant, or the patient has done the massage and it's fine, and it won't happen again and again. Leg cramps will be definitely be preceded by certain things. While the when we're talking about the RLS, it will be a frequent repetitive problem which the patient will have for few days, few months, depending on the onset of the disease. While coming to the neuropathy, obviously it will be with the origin. The patient will have some other metabolic disorders associated with it, which is predisposing to it. And there will be nerve sensation. So we can do the nerve studies also, nerve conduction studies, to understand basically if there's any cause in the nerve issues.
I think very well said that if you're suspecting leg cramps, probably we must check our electrolytes, calcium levels. Vitamin deficiency needs to be ruled out when you're looking at neuropathy. And yes, definitely a nerve conduction study and an EMG should be looked into. Also, spinal compression, spinal involvement, probably an MRI spine, LS spine is something we need to see. It's increasing. Our spine surgeons have got excessive work nowadays because of posture, because of obesity, which has taken our Indian population like a pandemic, so to say. So well said. Saurabh, I want to ask you a very tricky question, which we've been asked by Dr. Himanshu, that does RLS and PLMI have an associated neurocognitive disorder?
So, since the centrally, if we see, dopamine has a central role with both the things. So, mechanism is somewhat similar, but neurocognitive disorder can we categorize in the same this thing? They are part of spectrum of like similar, basically chemical. You can say whatever dysregulation is there in part of dopamine. But categorizing in a part, because we see when we treat both the condition like RLS and PLMS, so the dopamine is the central role has in the RLS. Well, in PLMS, it has partly, we can say sometime. So it can be rightly related with the, if it is associated with RLS, then it responds. Otherwise, there could be other cause also. So I don't know if I have answered very well to this question,
You
but
have.
so these are the part of the spectrum of the same chemical dysregulation that I can say.
Yes, so neurocognitive disorders are associated with RLS and PLMI. We also need to understand that about 30 to 40% of patients with RLS have a concomitant ADHD, attention deficit hyperkinetic disorder, more so in the younger population. And yes, anxiety and neuropsychiatric disorders are known to coexist with RLS, which is why when we're dealing with a pure RLS, it makes sense to have a multidisciplinary approach with a psychiatrist to offer the best possible treatment to the patient to understand if there is any other coexisting neuropsychiatric disorder or a cognitive disorder which is there, which probably will be missed by us since we are not equipped or used to dealing with these patients. A
If,
follow-up question. Yes, sir.
sorry, Bansal, if I can add,
Of course, sir.
if it is very clearly mentioned about PLMD causing cognitive and mood effects, and it's linked to very poor memory, attention span, and mood disorders such as depression, very well linked to it. So especially PLMD rather than RLS.
So RLS is linked with ADHD, yes, because it's anxiety and stress, which is a concomitant risk factor. And when we look at PLMD, it's a poor quality sleep. So it's a fragmented poor quality sleep. And any disease or any disorder which causes a poor quality sleep essentially has a daytime somnolence, daytime fatigue, neurocognitive disturbances, poor memory, and increases the risk of neurocognitive disorders, even seizures, migraines, and stroke. All the risk factors which we see with obstructive sleep apnea, the PLMI itself can give rise to those risk factors. Very well said, Sir Satish. I've got a follow-up question by Dr. Sarkar from Calcutta. He asks, what is the natural course of RLS? What happens if we don't treat it? Does it worsen with time? Does it remain the same? Because we've got patients with RLS living with them for years and often they've not even known that they've had RLS. So why should we treat it?
I think in my answer to your question posed on prognosis for RLS, I think I was mentioning about, it fluctuates, sometimes it increases, sometimes it decreases. There is nothing like a cure for RLS. And it varies from, age to age, and different age groups have problems. So why it is important to recognize this? As we said, that it's also associated with sleep apnea and its indirect impact and consequences of sleep apnea. So that's why I think it's important to recognize RLS, not merely because patient has those, those urge to move the legs and compelling reason for moving the leg, but also because it has an indirect effect through sleep apnea, the consequences of it. I think that's why it's important to diagnose RLS.
And also, it's important for us to treat RLS because, like we've said and we've spoken, that it worsens the sympathetic activity. The sympathetic activity has an overdrive, and concomitantly, you will have a worsening of cardiac comorbidities, hypertension. So, yes, an increased risk of morbidity is there. It worsens daytime symptoms of fatigue, sleepiness, daytime somnolence. So, the overall quality of life is impaired. So, if you ask me, should you treat someone with a poor quality of life, you've got the answer yourself. Now, we're not talking about pharmacotherapy or non-pharmacotherapy. Essentially, a patient has come to you with a poor quality of life. It's mandatory and you're obligated to help him solve or her solve their problem of the quality of life which is caused by the RLS. Now, the way you solve it is up to you, but it does require treatment. It will worsen with time. It's not going to get better because we've not addressed the underlying cause, whether genetic, whether pathophysiological, and only the factors and symptoms will worsen. Now, the last question which I'm going to ask my esteemed panelists, I've got so many more, but I just can't ask all of them, is something for today's day and age, is to Dr. Sajitha. Madam, does wearable technology and trackers have any role in RLS and PLMI?
Beg your pardon? I didn't quite
Does
catch.
wearable technology have any role in diagnosing and aiding RLS and monitoring RLS and PLMI? Wearable technology, your watches, smart watches, actigraphy,
Okay.
sensors. Yes.
Yeah, actually, we have new CPAP, diagnostic polysomnographs coming in, and incorporating that may to your daily sleep rhythm may help actually. But I really don't know whether the technology has progressed that much. Probably we can do. But as we all know that we require a level 1 study for this PLMS because we do need a limb movement recorder and your stages of sleep. So I don't know whether technology will have progressed that much, whether we can record the stages of sleep along with the movement disorder along in a small device as such as that. But hope we realize that. I don't know whether I've answered the question well. I hope the other panelists can contribute to that. Or Dr. Avya, your views on that.
I think wearable technology does have a role. Actigraphy does help us. Now, if we've got any device which tells us that there's nocturnal hypoxia, yes, it will help us understand that it is a risk factor for PLMI and RLS itself. Wearable technology during the day, probably sensors telling us the incidence of the RLS or how often the patient is moving the legs at night, whether the treatment is having an impact, a positive impact typically in the PLMI. We can't have a polysomnography routinely being done. It's an expensive test. It's frustrating. And often we advise a level 1 study or a level 2 study to our patients, but have we ever undergone the test ourselves? Imagine all those electrodes sticking and jutting over our forehead, limbs, and legs and asking us to sleep like a robot. It's just not possible. So something simple to track, to monitor. We also have bed sensors. We've got devices which are attached below the bed which monitor movement. Yes, it works. Probably cameras in the room do work. So yes, technology should be used as an add-on for monitoring therapy, I would say. For diagnosing therapy, we still quite far off from medical grade devices, and I would stick to probably a level 1 polysomnography. Those are my views. I think, do any of my panelists want to add anything in this?
On a lighter note, the bed partner, the old technology.
Yeah.
Which Dr. Singh was mentioning about it. So pay attention to her and him, saying, taking the detailed history, how disturbed it is. And you also mentioned that sometimes, they don't sleep in the same room. They're, sleeping in another room because of severe disturbance that impacts life. That's what I can add.
The partner is always right. The successful, and happy, healthy marriage life is ensuring the partner is right.
There are some apps which I just want to add. There are some apps which can help you know that what is the sleep duration.
Correct.
Okay.
So that can still help. And obviously, the other parameters like heart rate and how the add-ons parameters are. So that can substitute. Not I can say can diagnose, but it can help on.
It does help. It does help. Very important point about wearable devices telling us the sleep pattern, sleep latency, and sleep hygiene. It's good. It's still not medical grade because we don't have neurological activity. Alpha, beta, delta waves are still very important for us to understand whether there's actual sleep or the patient is completely relaxed. Also, these devices have to be taken with a pinch of salt when we're dealing with athletes. If people who are absolutely fit and they are athletes and they're sleeping straight, their activity is going to be very, very similar in sleep and in a resting state. So the fluctuation is going to be lesser. So in individuals who've got a larger variable or a larger fluctuation, wearable devices are more accurate for the sleep hygiene. But yes, definitely some information is better than no information. On that note, my final comments from my panelists, starting from Satish sir, and take home messages, please.
Thank you. Was an excellent learning, excellent webinar. I learned a lot actually. And to stay so far, actually, I was supposed to leave at 10 o'clock, but I stayed back because of overwhelming question. There may be some question which, I may need to address it. Thank you very much for the webinar, and excellent. You conducted very well. Great, Bansal. Thank you. And just to say about the topic itself, it's not uncommon. RLS, PLMS, pay attention to the patient and look into the last part of the report, and not to neglect it, and then try to help the patient whatever you can. Non-pharmacological treatment, pharmacological treatment, or consult a colleague, and if you are not sure about it, and definitely addressing that will, especially PLMS, has a direct consequence on, similar to an obstructive sleep apnea, the complication, cardiovascular complication, the strokes, the arrhythmias, and everything related to it. Yeah, thank you.
Thank you, sir. Sajitha, madam, your thoughts, final take-home comments?
Actually, all of them have been very well explained by Satish sir, so I'm not adding to that. At the outset, I'll thank ICS and Ankita ma'am for this wonderful webinar, and it was a very well taken topic, and it was a well organized class by Dr. B P Singh, and very well summed up by Dr. Avya. Every salient point was highlighted by him. Excellent coming up. And I would like to thank all my panelists also, Dr. Saurabh, Dr. Ankita, and Dr. Satish, for their excellent contribution. And actually, I've learned much more from listening to them. And I'm very happy with, that we have so many delegates who have asked such meaningful and in-depth questions so that we could think more about this. So thank you very much. It was on the whole a very fruitful session, I guess, for all of us.
Dr. Gupta, your thoughts?
Thank you so much, Amita ma'am and ICS and CIPLA for including me in this wonderful learning experience. This was amazing. Listening to Dr. B P Singh sir and all our esteemed panelists, it was an overwhelming experience. And Dr. Avya, you were very, very, very well versed with the topic, and you have conducted so well. I really guess that all our listeners have really learned today and will take a lot of good message that yes, every disease is important, every entity is important. We have to listen to our patient and we have to understand what they're having a problem. And yes, if they have the problem, we are the one who are supposed to cure it. Thank you.
Thank you, Dr. Gupta. And last but not the least, Saurabh.
Yes. So thank you very much first, ICS, Dr. Amita ma'am, and excellent moderation, Dr. Avya. So I have got a lot of insights today from today's talk. And if you ask me, and a single message for today, so like we have discussed, the first treatment is placebo. So we should not jump directly onto, drugs directly and start treating with a lot of drugs. So non-pharmacological treatment is also there. So that needs to be keep in mind.
Thank you so much.
Thanks a lot. Thanks to all the panelists. Thanks to Dr. Satish sir.
I'd like to just add one line that when we call ourselves sleep doctors or sleep medicine specialists, we must not just focus on obstructive sleep apnea. It's just the tip of the iceberg, and there are so many sleep disorders which are left untouched and unaddressed by us. We speak of multidisciplinary approach in the treatment of so many respiratory disorders, typically ILD, pulmonary hypertension. So why not sleep medicine? If you're stuck, go to an ENT colleague, reach out to a psychiatrist or a neurologist, have a teamwork, and try to offer the best to your patient at the end of the day, because that is what sleep medicine is all about. It's 33% of your entire life summed up in a nutshell. And if you don't give importance to your sleep, I don't know what is there to give importance to. So on that note, I'd like to thank all my esteemed panelists, Satish sir, Sajitha madam, Dr. Gupta, Dr. Saurabh, and B P Singh sir, who had to leave early. I would also like to thank the Indian Chess Society for organizing this sleep certification course, which has been the brainchild of Dr. Amita Nene, and CIPLA for being the academic partners of this wonderful event, especially Hitesh for being wholeheartedly involved right from the start in all the modules, and looking forward with more modules for all of us. And I hope all of us can learn a lot from this sleep certification course, and it only gets better with time to come. So thank you, everybody. Good night. Thank you.
Thank you. Thank you.
Good night. Good night, everyone.
Good night.
Thank you.